Genetics. Prep Core Pediatrics. Key definitions in genetic disorders. Preview, review. Define the following terms: congenital, hereditary, family, genotype, phenotype, variable expressivity, mosaicism, heterozygous, homozygous, autosome, and syndrome. At first glance, you might think that congenital, hereditary, and familial all mean the same thing, but they don't. For example, trisomy 21, infection with rubella, and amniotic bands are all congenital conditions. Congenital refers to a condition or anomaly present at birth. Of the three, though, only trisomy 21 is a genetic condition. Hereditary refers to conditions that are genetically transmitted from parent to offspring. All hereditary conditions are genetic, but some individuals with genetic disorders are a result of a new mutation in the family and are unable to reproduce. Thus, not all genetic conditions are hereditary. Family refers to conditions that cluster in families and can include genetic as well as non-genetic, e.g., attention deficit hyperactivity disorder, ADHD, high blood pressure conditions. All hereditary conditions are familial. All hereditary conditions are familial, but not all genetic conditions are familial. As examples, achondroplasia is congenital, hereditary, and familial. Breast cancer is not congenital, can be familial, and a small portion is hereditary due to mutations in BRCA1 or BRCA2. Trisomy 21 is congenital and, in the majority of cases, not hereditary and not familial because the individual is usually the first case in the family and does not reproduce. Keep in mind that 5% of trisomy 21 cases are due to unbalanced translocations, which can be hereditary and familial if passed down to more than one individual. A balanced translocation occurs with an even exchange of material, resulting in no extra or missing genetic information and ideally full functionality. An unbalanced translocation occurs when there is unequal exchange of chromosome material, resulting in extra or missing genes. Genotype refers to the genetic condition or different forms of a gene alleles at a given locus on a chromosome. Although each individual has only 2 alleles, there may be more gene variants in the population. Phenotype refers to observed expression, physical, biochemical, or physiologic findings of the genotype or gene mutation. Genotype may or may not be apparent in an individual's phenotype. Penetrance is the ability of a known disease-causing genotype to exhibit the disease phenotype. Reducing or incomplete penetrance means that some people with the disease-causing genotype do not have evidence of the disease. A common example is retinoblastoma. About 10% of people who have an autosomal dominant AD retinoblastoma-causing mutation do not actually develop retinoblastoma. Thus, the penetrance for this condition is 90%. Variable expressivity is when individuals have the same genetic condition, even the exact same genotype, but have varying degrees of the phenotype. For example, Treacher-Collins syndrome is an AD, autosomal dominant, craniofacial malformation syndrome. Within the same family, some individuals with Treacher-Collins gene have cleft palate, whereas others with the exact same mutation do not. In genomic imprinting, expression of the gene depends on whether the gene was inherited from the mother or father. Imprinting turns off genes. Thus, if a gene is paternally imprinted, the allele derived from the father is inactive and only the maternally derived allele is expressed. If a gene is maternally imprinted, only the paternal allele is expressed. Examples: Prader-Willi syndrome, paternally derived, 15q11, 13 deletion, and Angelman syndrome, maternally derived, 15q11, 13 deletion. Pleiotropic refers to genes that produce many effects. An example is Marfan syndrome, which can affect the eyes, cardiovascular system, and skeletal system. Mosaicism is the presence of greater than or equal to 2 genetically different sets of cells in the same person caused by an error in mitosis. Examples: majority of Turner syndrome cases. Heterozygous refers to 2 different alleles at a gene locus on a pair of homologous chromosomes, whereas homozygous refers to identical alleles at a particular gene locus. A mutation is a term used to describe a change in the DNA code. Autosome refers to all chromosomes except the X and Y chromosomes. There are 22 autosomes, chromosome numbers 1 through 22, and 2 sex chromosomes, X and Y. The majority of the population has a total of 46 chromosomes, 2 copies of each autosome in either XX female or XY male to determine the sex of the person. Non-disjunction occurs when the homologous chromosomes or chromatids fail to separate, resulting in aneuploidy, an abnormal number of chromosomes in the daughter cells. In clinical genetic terminology, an anomaly is a structural birth defect or congenital malformation. Multiple anomalies can form recognized patterns of malformation known as complex, syndrome, association, or sequence. Complex anomalies of several different structures that are near each other during embryonic development, developmental field, e.g., limb-body wall complex. Syndrome, a recognizable pattern of structural defects due to a known single genetic etiology with a predictable natural history that remains relatively consistent across unrelated patients, e.g., Cornelia de Lange syndrome, Williams syndrome. Association, anomalies seen together that do not have a known single genetic or developmental etiology, e.g., VACTERL association, vertebral defects, anal atresia, cardiac defects, tracheoesophageal fistula, renal anomalies, limb abnormalities. Sequence, a pattern of multiple anomalies caused by a single identifiable event in development, e.g., Pierre-Robin sequence. Risks of genetic disease and diagnostic testing. Preview review. What are some indications that a genetic disorder is likely? A positive prenatal quad screen indicates an increased risk of which 4 disorders? What diagnostic testing method is used to detect single gene defects? Genetic disease risk factors. Many parents are concerned about genetic diseases and specific risks for their child. Once a child is born with an abnormality, many parents want to know if this is genetic and therefore whether the abnormality could happen again. Clues that a genetic disorder is likely: previous family history of genetic disorder, positive neonatal screen, congenital anomalies, developmental abnormalities, neurologic disorders, death in utero or soon after birth, growth abnormalities, multi-organ dysfunction. Indications for chromosomal analysis: multiple birth defects, developmental delay, intellectual disability, autism, growth abnormalities, e.g., short stature, abnormal sexual development, recurrent miscarriages. Prenatal testing. Prenatal screening tests tell if a fetus has the possibility of having a genetic disorder. Maternal blood screening, aka quad screen, is performed between 15 and 18 weeks of gestation. It measures alpha-fetoprotein, human chorionic gonadotropin, estriol, and inhibin A. The results measured as a risk ratio indicate the likelihood of a trisomy 21, trisomy 18, neural tube defects, and abdominal wall defects. If the risk ratio is increased, then further diagnostic testing is needed. Prenatal testing. Prenatal screening tests tell if a fetus has the possibility of having a genetic disorder. Maternal blood screening, aka quad screen, is performed between 15 and 18 weeks of gestation. It measures alpha-fetoprotein, human chorionic gonadotropin, estriol, and inhibin A. The results measured as a risk ratio indicate the likelihood of trisomy 21, trisomy 18, neural tube defects, and abdominal wall defects. If the risk ratio is increased, then further diagnostic testing is needed. Screening for chromosomal disorders also includes cell-free fetal DNA. Remember, this is a screening test with low false negative and false positive results. Prenatal diagnostic testing, on the other hand, tells if a fetus actually has a disorder. Some of the modalities used for diagnostic testing are ultrasound, amniocentesis, chorionic villus sampling, placenta, and umbilical blood sampling. Cells collected from these invasive procedures can be sent for karyotype, gene testing, single genes, or short DNA segments, or biological testing, protein amounts, or activity. This information is limited, however, in that the test does not reveal how severe the symptoms will be in the patient, and once diagnosed, many genetic disorders have limited treatment options. Some of the heritable disorders that can be diagnosed prenatally include cystic fibrosis, Fragile X, hemoglobinopathies, and Down syndrome. Postnatal diagnostic testing. Postnatal diagnostic testing is performed on the baby's blood, cord blood, products of conception, or solid tissue. Large defects in the chromosome, aneuploidies, large deletions, translocations can be detected by karyotyping, fluorescent in situ hybridization, FISH, and comparative genomic hybridization, also called chromosomal microarray or SNP array. FISH uses fluorescent labeled single-stranded DNA probes that hybridize with the target DNA sequence, revealing the defect. Comparative genomic hybridization compares the DNA of a patient with that of a normal control to detect any abnormalities. It is a first-line test for non-dysmorphic patients with intellectual disability, autism, and multiple congenital anomalies. Be aware that this test looks for missing or extra material but does not detect chromosomal arrangements or indicate where extra material is located. Single gene sequencing is typically performed with the Sanger method. Multiple gene panels and whole exome sequencing use next generation sequencing methods. Older methods such as Southern blots are still used to detect trinucleotide repeat disorders and methylation disorders. Chromosomal defects. Preview, review. What is a genetic abnormality in trisomy 21? What is considered to be the etiology of trisomy 21? What is the only factor known to increase the risk of trisomy 21? Which screening tests indicate an increased risk of trisomy 21? What are some of the classic physical findings in children with trisomy 21? What are the common congenital heart defects found in a child with trisomy 21? Which GI defects are associated with trisomy 21? Which glandular disorder should you annually screen for in adults with trisomy 21? A 30-year-old mother has a child with trisomy 21 with 3 complete copies of chromosome 21. What is her risk of having another child with trisomy 21? Is trisomy 18 more common in boys or girls? What are the classic features of a child with trisomy 18? What are the classic features of a child with trisomy 13? Describe a girl with Turner syndrome. Describe a boy with Klinefelter syndrome. Describe a child with Williams syndrome. What characterizes Wager syndrome? Describe the classic findings in Alagille syndrome. What are the most common cardiac abnormalities in Alagille syndrome? List the classic findings of 22q11.2 deletion. Overview. Large chromosomal abnormalities due to abnormal chromosome number associated with physical and developmental delay are known as aneuploidy. Aneuploidy can be either monosomy, the loss of one chromosome, only one is compatible with life in humans, 45X Turner syndrome. Trisomy, the gain of one chromosome, the most common include trisomy, the gain of one chromosome. Most common include 47 plus 21, Down syndrome, 47 plus 18, Edwards syndrome, 47 plus 13, Patau syndrome, 47XXX, 47XXY, Klinefelter, 47XYY. The main risk factor for aneuploidy, except Turner syndrome, is increasing maternal age. Autosomal trisomy syndromes. Trisomy 21, Down syndrome. Incidence screening. Trisomy 21 is the most common autosomal trisomy in humans, occurring in 1 over 800 live births. The incidence at conception is more than 2 times the incidence at birth because greater than 50% of those with trisomy 21 at conception spontaneously abort during early pregnancy. Approximately 95% of those with Down syndrome have 3 copies of the whole chromosome 21. Around 3 to 4% have only part of the long arm due to translocations with chromosomes 13, 14, or 15, and the remaining 1 to 2% have mosaicism. Trisomy 21 is caused by the extra copy of chromosome 21. Thought to be due to non-disjunction during meiosis, the only factor shown to increase the risk of having a child with Down syndrome from non-disjunction is increasing maternal age, especially mothers greater than or equal to 35 years of age. No environmental factors have been implicated. Prenatal screening, e.g. quad screen, quadruple marker test, is commonly performed in pregnant women during the 2nd trimester to assess for Down syndrome risk. A concerning maternal serum screen shows low maternal serum alpha-fetoprotein, low unconjugated estriol, elevated HCG, human chorionic gonadotropin, and elevated inhibin levels. Many providers add early ultrasound with measurement of the baby's nuchal translucency, neck thickness, and serum markers to the prenatal screening to improve sensitivity and specificity. DNA-based maternal blood screening using free fetal DNA found in the mother's blood is available as well. It has much higher sensitivity and specificity than the above screening methods, but it is not perfect. Use of this technology is rapidly increasing and will likely replace serum marker screening entirely in the future. Presentation. Down syndrome presents with a classic phenotypic pattern, but if taken singly, many of the findings are minor anomalies or non-specific. For example, if you have a single transverse palmar crease, as 10% of you do, that doesn't mean you have Down syndrome. You need the whole picture to make an accurate diagnosis. Typical features: hypotonia, poor motor reflex, intellectual disability, brachydactyly, short, broad fingers and toes, especially note the broad space between the first and second toes, upslanted palpebral fissures, flat midface, full cheeks, protruding tongue, epicanthal folds. Single transverse palmar crease, brush-field spots, whitish spots in a ring-like configuration at the surface of the iris, high arched palate, hypoplasia of the middle phalanx of the fifth finger, and clinodactyly. Trisomy 21, brachydactyly, and broad space between first and second toes. Single transverse palmar crease. Heart defects. Heart defects are common in Down syndrome, occurring in nearly 50% of patients, with up to a quarter of these having more than one anomaly. The most common defects are atrioventricular AV canal defects, ventricular septal defects VSDs, and atrial septal defects ASDs. Less common lesions include tetralogy of Fallot and patent ductus arteriosus. Remember that AV canal defects frequently do not have an associated murmur because about 50% of children with Down syndrome have congenital heart defects. Echocardiogram is mandatory for all children with suspected Down syndrome. And GI defects. Duodenal atresia and Hirschsprung's disease occur in 5 to 10% of infants with Down syndrome. Look for the classic double bubble sign indicating the duodenal atresia on abdominal x-rays. For more information, see the gastroenterology section. Double bubble sign and duodenal atresia. Ocular problems. Congenital cataracts occur in about 5% of newborns with Down syndrome, but the risk of other problems such as strabismus, refractive errors, and cataracts increase with age. Therefore, ensure that careful routine ophthalmologic evaluations take place. Developmental disorders. Children with Down syndrome have developmental delay with mean IQ scores ranging from 50 to 70. However, social performance is beyond that expected for the mental age. Almost all children learn to walk and communicate, and most progress at a steady but slower pace than usual. Encourage early intervention programs to accelerate milestones in the younger years. Other problems of Down syndrome in childhood. Other problems in childhood can include hypothyroidism, atlantoaxial C1-C2 instability, leukemia, particularly acute lymphocytic leukemia, particularly acute lymphocytic leukemia, and celiac disease. Check thyroid function studies at birth, included on newborn screen at 6 and 12 months, and then annually. Evaluate these patients for atlantoaxial instability, especially prior to sports participation. If the patient is having symptoms or the exam is abnormal, order cervical imaging and consult a neurosurgeon or orthopedist. Spinal cord injury may result when atlantoaxial instability results in subluxation or dislocation of the first and second cervical vertebrae. It is a manifestation of the generalized poor muscle tone and joint laxity common in trisomy 21. Transient myeloproliferative disorder. A unique condition that can occur in patients with Down syndrome is transient myeloproliferative disorder. A unique condition that can occur in patients with Down syndrome is transient myeloproliferative disorder, aka transient leukemia. This type of leukemia occurs in up to 10% of all infants with trisomy 21 and occurs within the first 3 months of life. A mutation in the GATA1 gene is the cause. Transient myeloproliferative disorder is characterized by the presence of blast cells, most commonly megakaryoblast, in the peripheral blood, which can number as high as 200,000 per microliter. In contrast to acute megakaryoblast leukemia, the percentage of blasts in patients with transient myeloproliferative disorder is lower in bone marrow than in peripheral blood. Bone marrow cytogenetic analysis is negative for all clonal abnormalities other than trisomy 21. Most patients are asymptomatic with the exception of vesiculopustular skin lesions, which contain cells similar to blast cells. Patients usually undergo spontaneous resolution within the 3 months of life as the numbers of blast cells gradually decrease. A small number of patients, especially those born prematurely, can experience severe complications including hepatic fibrosis, generalized edema, multiple effusions, and cardiopulmonary failure. In these patients, treatment with chemotherapy is warranted. Closely monitor patients with a history of transient myeloproliferative disorder as they grow older because there is a 10 to 20-fold increased risk of developing acute myeloid leukemia. Problems of older patients with Down syndrome. Patients with Down syndrome can develop problems later in life in their 3rd, 4th, or 5th decades. However, because many pediatricians remain the primary care physician for some patients with Down syndrome, even after they advance to adulthood, Remember to vigilantly monitor for these long-term complications: type 2 diabetes, thyroid disorders, both hypo and hyperthyroidism, atlantoaxial subluxation, performing screening x-rays prior to sports participation, cataracts, leukemia, seizures, cognitive dysfunction during the patient's 40s, dementia, or early onset Alzheimer's disease. Health supervision guidelines. The AAP publishes health supervision guidelines with anticipatory guidance for children with Down syndrome. As of 2018, these include all routine immunizations, cardiac evaluation with echocardiogram in the newborn period, ophthalmologic evaluation before 6 months of age, hearing evaluation during newborn screening, and again by 6 months of age. These thyroid studies: newborn screening for hypothyroidism at 6 and 12 months, then annual T4 and TSH throughout childhood and adulthood. Vision screening at 4 years of age, screening x-rays for atlantoaxial subluxation prior to sports participation. Future risk of sibling with Down syndrome. If the child has 3 complete copies of chromosome 21 and the mother is less than 35 years of age, her risk of having another child with trisomy 21 is 1%. If the mother is greater than or equal to 35 years of age, the risk is similar to the age-specific risk. Remember, risk for having a child with Down syndrome increases with increasing age of the mother. If the child with trisomy 21 has Down syndrome due to an unbalanced translocation, the future risk depends on whether one of the parents has an abnormal chromosome. For example, if the parent has a 21-21 translocation, the risk of having an offspring with Down syndrome is 100%. Besides the 21-21 translocation, if the father has a balanced translocation between 21 and another chromosome, the recurrence risk is 1 to 2%. If the mother has a balanced translocation, the recurrence risk is 10 to 15%, although trisomy 21 is most commonly a sporadic condition, 95%. It is hereditary when due to an unbalanced translocation inherited by the parent. It is hereditary when due to an unbalanced translocation inherited from the parent. Obtain a karyotype to determine the recurrence risk.